Okay, good evening, everybody, and thank you for taking the time to be with us here this evening. We do have Spanish and Portuguese interpretation available for those who are listening to the webinar. You can click on the interpretation button, which is usually at the bottom right of the screen, and select your preferred language to listen to this presentation. We are here tonight to talk about the new COVID vaccines that are becoming available in the hope that we can all understand a little bit better how they work and when we will be getting them and the medicine that is behind the vaccine. And so we're very thankful to have Dr. Kong, Dr. Golenbach, Dr. Ingalls, and Dr. Levitz here with us to discuss the vaccine and then to answer questions that folks may have. I want to begin tonight by recognizing what's happening in our nation's capital right now. It's both shocking and heartbreaking, and nothing that I ever thought that I would see in the United States of America. Very troubling, without a doubt. And our administrative team is actually working right now in a different venue to put resources together for teachers and students to help the kids along with the adults figure out how to process these riots and the underpinnings of this violence and encourage students and help them to share their feelings and know that ultimately we will be safe through this period of turmoil. But before we move on to talking about the vaccine, which in itself is an important topic, I think the mayor wanted to have a few words to just address the violence in our nation's capital. So I'll turn it over to Mayor Arrigo.
Yeah, thank you, Dr. Kelly, and thank you to everyone that's watching this evening, and thank you to the panel for taking the time to help inform our community. Obviously, today's events are heartbreaking. As a former DC resident, I have a special place in my heart for that city, and to see what's unfolded really hits home. And what we're seeing is really sad, but I think the saddest part of the whole situation is how predictable it is and has been for the last several weeks. What we're seeing, or what we've seen today, is an attack on an assault on our democracy. And as I said, it has to be condemned. It has to be acknowledged. And I appreciate Dr. Kelly for allowing me the time to just acknowledge the fact that this has happened, and to let our residents, our students, our families know that we are preparing to have support services available. And I thank Dr. Kelly for being so proactive and being able to make sure that our students are able to process these challenging things that we're seeing unfold. And again, I appreciate the fact that we are able to have those kinds of supports available, and that we're focused on making sure that our families and our the children in the district can handle the trauma that they're seeing unfold on TV. With that, I do, as Dr. Kelly said, want to impress upon the fact that we are here to create safe spaces for our residents and for our families, and we will continue to do that. And what we're seeing is certainly some of the worst that we've seen, actions that again are an assault on our democracy and our way of life. And I know that better days are ahead, but it's really a heartbreaking scene to watch what's happening in the Capitol. With that, I know that we are here to talk about the vaccine, and I appreciate the team that Dr. Kelly's assembled here to discuss the vaccine. Being able to provide educational information to our residents is incredibly important, and I just want to thank everyone that's here with us tonight. I have the honor and pleasure of handing it off to our Board of Health chair, and someone who has been an incredible asset to the city of Revere through really challenging time with COVID-19 hitting so hard. Dr. Kong has done an amazing job saving lives for our residents, and I can't thank her enough for all the incredible time and work and effort that she's put in to help us. So thank you, Dr. Kong, and I will pass it off to you.
Thank you very much. Good evening, everyone, and thank you for joining us tonight. I just want to give a shout out and a thank you to Diane and Richie and their whole team for working to organize this. As usual, they are always hard at work, and I don't know when they ever sleep. And shout out to the mayor for that lovely introduction and for always giving me the space to speak directly with the residents of Revere. I also want to kind of kick things off by just addressing the elephant in the room and what's happening tonight in DC. I think some of why this is happening today is because of a lot of misinformation that has been spreading about the election and about the process of picking a transferring power. And I think that is something that we should take with us as we work to address any misinformation this evening about the virus and about the vaccine. I know I'm speaking to a lot of educators out there, so I know you all know the value of the truth and how empowering that can be. So hopefully we can kind of wade through that together, both through as it pertains to the virus, but other aspects of our society, since it seems that the truth keeps getting muddier and muddier as the days go on. I also want to just start off by acknowledging just how challenging this year has been for all of us. Since March 2020, the coronavirus has upended literally every piece of our daily lives. And it's done so in the most profound ways. As we head into the 1-year mark since the pandemic began, I can only imagine how exhausted and emotionally drained all of you are, parents and educators especially. The light at the end of the tunnel for some is a coronavirus vaccine that came out just last month. While for me, the virus has been a huge blessing, for many of you and many of my patients too, this vaccine only represents even more anxiety and uncertainty and confusion. It's a lot to take in, and it's a lot to process during the tail end of an already challenging year. So this evening, we've gathered our specialists in infectious disease from UMass and from Boston Medical Center to answer any and all of your questions as it pertains to the vaccine. So no question is too small. Please kind of get it all out there. We'd rather we answer any type of hesitancy or any questions you guys have. I also ask that despite your fears and your anxiety and all of your exhaustion, that you just keep an open mind when listening to these talks. Because I think it's just important to make sure good quality evidence hits the ears of all of our residents. I'm going to close my statement by just sharing with you all the reason why I got my vaccine. I already got it. I got it about a month, or I got it last month, and I'm looking forward to getting my second dose in about a week or so. And the reason I got vaccinated is because I don't want to lose any more than we already have to this virus. We've lost so many lives already, 350,000 and counting. But we've also lost the opportunity to celebrate birthdays, weddings, baby showers, graduations, all right? We've missed out on holidays with loved ones, concerts with friends, Little League games with our kids. We've missed out on so much. So I got my vaccine because I am done losing lives and losing these precious moments with my loved ones. So I hope that you will all join me in preventing any further loss in our city and our country. So thanks for listening. And I'm going to now turn it over to Doug Gollenbach from UMass Medical, who's going to go over his slide deck on the coronavirus vaccines.
Great. Thanks very much, Dr. Kong. Who can share? I'm going to share my screen. I think this is right. My goodness. Let's see. There we go. All right. Everybody can see my shared screen, I hope.
Yep, I can see it.
Okay, great. So yes, it's a bleak day, I know, but there is some good news here. And the vaccine is our good news. It's the best news that we've had since the pandemic began. I won't say that the vaccine all by itself will bring us back to normal living, but it is going to be a big change. It's going to change this pandemic dramatically. So, how do I get that? So this is a cartoon of what the SARS-CoV-2 virus looks like. And this is the virus that causes COVID-19. So we can see here that SARS-CoV-2 on its surface has a protein. And this protein is called the spike protein. It comes in two forms, and that's not particularly important. But this spike protein is very, very important because the spike protein binds cells in our respiratory tract and actually infects us. It binds something called the angiotensin converting enzyme 2 receptor, which is just a protein on the surface of human cells to which the virus can bind and get into human cells. And from there, once it does this, once the cells get into the respiratory tree and they're infected, the cells in the respiratory tree are like a factory. They churn out virus, billions and billions of them. And those viruses get into other cells, and ultimately you get inflammation in the lungs and in the kidneys, and actually certain terrible things can happen in your blood, resulting in COVID-19. So the virus is particularly well prepared using this spike protein to invade the body and cause problems. So the goal of the vaccine is to tell the immune system or trick the immune system into thinking that there's been a virus so that you get an immune reaction before you actually get infected. And so what people have done who've invented the vaccine is to make a vaccine that produces the spike protein that binds to cells. And the result of that is that the immune system sees this spike protein, but it doesn't see it like it would see a normal protein that humans make. It sees it as a foreign protein. And ultimately, the immune system is trained to kill the virus by producing antibodies. That's what these green things here are meant to represent, and what are called killer T cells. And those killer T cells see infected cells as if they're foreign and go ahead and kill them and limit the growth of the virus. So there have been two vaccines that have recently been approved for emergency use in the United States, and they are fantastic. Now, these vaccines are nearly identical. They're called mRNA vaccines. They consist of something called messenger RNA or mRNA, and mRNA is how the cell tells, how the DNA in your cell instructs the cell to make proteins. So cells need proteins. We all need to make proteins to make muscle and connective tissue and all the good things. And in this case, the vaccine's got messenger RNA in it, and it instructs the cells to make spike protein. And that spike protein gets expressed on the surface of cells and taken up by immune cells, which then ultimately make antibodies and lymphocytes that kill infected cells. So there are two vaccines that have been made, and both of them are very, very effective and remarkably safe. And I'm going to talk about them as if they're identical vaccines, because really they are almost identical in every sense. They differ a little bit, but we don't exactly know how they differ because these are proprietary secrets, industry secrets, but they only differ by what they're mixed with before they get injected into humans. So one is made by Pfizer and BioNTech. Those are two companies that have formed a collaboration. It's called BNT162b2. And the other is by a local company called Moderna. This is a company in Cambridge, Massachusetts. And they have a vaccine called mRNA 1273. And as I said, both of these vaccines are essentially identical. And this just shows what happens. If you get 2 shots of the vaccine, you have a 90% effectiveness. So let's just go over this graph right here. We have 2 groups of people. The people in blue here were the research subjects who were injected with placebo. And that placebo in this case turned out just to be saline or salt water. And the other group got the vaccine. That's the red group. And they got 2 doses. They got one on day 0. And for the Pfizer vaccine, they got one on day 21. And for the Moderna vaccine, they got a second dose on day 28. But basically, there's no real difference between 3 and 4 weeks. And you can see that after they got vaccinated, if we take this area here and we blow it up here, that somewhere around day 10, the people that got the vaccine in red stopped getting infected. And the people who didn't get the vaccine, who got the placebo, which was salt water, they continued to get infected just by going around in the community. They weren't challenged experimentally anything. They just got sick like our neighbors and friends who have gotten sick with COVID-19. And then the second dose of the vaccine was given about 3 or 4 weeks. And essentially you see that there are almost no infections once somebody gets the second dose. So I mentioned to you that this vaccine was about 95% effective at preventing infections and incredibly effective at preventing severe disease. So these are the results of the Pfizer study. They had 21,720 people that got the vaccine. An almost equal number got salt water. In the salt water group, the control group, they had 162 cases of COVID-19. 9 people ended up in the ICU on a respirator or on high flow oxygen. In comparison, in the group that got the vaccine, they had 8 cases of COVID-19. These were people who had mild symptoms. Only one of these people ended up in the ICU with severe COVID-19. The Moderna study is almost the same size. They had 14,000 people who got the vaccine and 14,000 got the control saline. Moderna had 185 cases of COVID-19 in the control group, of whom 30 of these people got severe COVID-19 requiring admission to an ICU, and they had 1 person die. So the only death that was seen in either of the studies was in the control group. This person got placebo. They had 11 cases of COVID-19 in the vaccine group, none of whom had severe disease. So think of this, between the 2 studies, they vaccinated somewhere around 36,000 people. And of those people who got vaccinated in a period of about 4 or 5 months, only 19 people got COVID-19 and only 1 of them got severe disease. But out of these 36,000 people, the 36,000 people who got saline instead of the vaccine, they had like 350 cases, of whom 39 got severe COVID-19 and 1 person actually died. So this is a very, very effective vaccine. There are a few vaccines out there that are as effective as this COVID-19 vaccine. Another really nice thing about this vaccine is it worked well in everybody. It didn't matter if you were young or you were old, or you had diabetes or you didn't have diabetes, or if you were obese or you had high blood pressure, or whether you were white or you were a person of color, or you had any number of comorbidities, you did very, very well. And that's what this chart here shows, is that the vaccine efficacy was about 95%, and it didn't matter on your age, your sex, whether you had comorbidities, or what your ethnic background was. The vaccine worked. Pretty remarkably, there were no major side effects seen in any of these research subjects, none, 0. It is true that people had arm pain and they had some issues with headache and fatigue and fever, although it became rapidly clear that if you took Tylenol or aspirin, that prevented a lot of these symptoms. We know that after the vaccine became approved and they were no longer vaccinating 60,000 people, but 2 or 3 million people, that a few people had allergic reactions to the vaccine. They had serious allergic reactions. It was very, very low. I think the side effect ratio was about 1 serious allergic reaction in 185,000 people, which is certainly acceptable, although we would like it to be better than that. Now, a very, very important issue here is pregnancy. The study was not designed to look at pregnant women, but humans being humans, people got pregnant during the study, and there were no side effects in any of the women who got pregnant, who also got the vaccine. The American College of Obstetrics and Gynecologists actually officially came out a few weeks ago and recommended that pregnant women should be vaccinated. Now, consider that pregnant women sometimes do very, very badly when they get COVID-19. This is really a welcome event that we now have something to prevent COVID-19 in pregnancy. Now, one, of course, important question is, when will I get the vaccine? If you're teaching in a school and you're worried about getting COVID-19, this, of course, would make you feel somewhat more comfortable. So there's been an advisory committee on immunization practices, the so-called ACIP. This is part of the Centers for Disease Control, and they came out with recommendations for who should be vaccinated first. Now, these recommendations are interim recommendations. They're somewhat in flux now, but there was a recommendation to break up the beginning of the vaccine rollout into phases. There's phase 1A, 1B, 1C. Phase 1A was for the frontline healthcare personnel and for people who live in long-term care facilities. About half the people who have died so far of COVID-19 have lived in long-term care facilities like nursing homes, for example. And this is a good way to cut down on hospitalization and mortality very quickly. They also next thought that essential workers and the elderly should be vaccinated, followed by people who are age 65 to 74 who have, and even younger, who have comorbidities or other medical problems like diabetes or hypertension. Well, who is an essential worker? It's not actually a small number of people. A lot of us are actually essential. Of course, firefighters and police, first responders are all essential workers. But look who's right here in phase 1B. Teachers and their support staff and daycare workers are right up there as the most essential workers who should get this vaccine first. And so I think we'll start to see a rollout in education probably within the next month. There are other essential workers who follow right behind. And of course, after that, as I mentioned to you, we'll be looking at people who have comorbidities, which are things like diabetes and high blood pressure. The Massachusetts COVID-19 website has priorities written. You can go to mass.gov/COVID vaccine and look this up if you wonder where you sit. But it's what I've just told you, that the first order of priority are going to be the healthcare workers and the people who live in long-term care facilities and the essential workers. And then we're going to start doing vaccinating people with comorbidities. Actually, this is a little bit old because early education has been moved up. The Governor's Advisory Task Force has confirmed that they believe that the ACIP recommendations from the CDC should hold, so that teachers are actually part of phase 1B. So we're looking forward to having teachers vaccinated, starting to be vaccinated in February. That is the end of my slideshow, so I'll stop right there and pass the baton to Dr. Ingalls.
Thank you, Dr. Goldenbach. Let me just share my, am I sharing it? No. Share screen. Let's see. Just to follow up on what Nat said, are you all seeing my screen?
I don't see it yet, Robin.
Ah.
You need to click the green share screen button at the bottom, and then choose your screen to share.
That's what I haven't done. Share, let's see.
Go.
All right.
Yeah, now, Robin.
Is that?
That's good.
Okay.
Perfect.
Just to follow up on what Natalie was saying at the beginning, I received my vaccine 2 weeks ago, and I did it to protect myself, I guess, first, but also to protect my patients and my family from COVID, and I don't want to transmit to them. I'm going to switch gears a little bit and just review some of the things that I talked about at our last webinar and just try to put the vaccine in a little more context. So just to review some of the things that we talked about before and expand, because we have learned more. So we do know that when schools are closed, it can have a significant negative impact on children, both their education, but also their mental and physical health. And it's complicated to reopen schools because we're really trying to balance the needs of three somewhat different populations. So we're trying to balance the needs of the children and their families against the needs of the teachers and the staff that are going to be in the school buildings, as well as the wider community, since we don't want to be spreading infection in any direction. But it's important, I think, for everyone to remember that we're actually all on the same team. We all have the same goals, which is to educate our children and keep our staff as safe as we can. And as we learn more, we must be able to be a little flexible in our plans and our decisions, and really pivot to maximize what we've learned from the science and use it to have a safe return to learning. So last summer, the Department of Elementary and Secondary Education, also known as DESE, came out with some guidance for different towns. And just to remind everyone, they asked towns and municipalities to come up with 3 learning models. So the ideal, of course, would be in-person learning, that we could all return to school, perhaps with some restrictions, but return full time, with the acknowledgement that it may not be safe to do so in some communities. So remote learning needed to be also planned for, as well as a hybrid learning model, which a number of towns have also selected. And in addition, last summer, they came out with a sort of color coding system to help towns determine what they should choose in terms of what type of learning to do. And as we've all seen over the last few months, the color coding of Massachusetts has really gotten a little bit frightening. And many of us, in the red and yellow zone right now. But we have to acknowledge that a lot of the metrics that we followed at the beginning of the pandemic really aren't useful anymore for telling us when it will be safe to open schools. We know so much more than we knew over the summer. And it's a little simplistic to say, if you're red, you should stay home, and if you're yellow, you should be hybrid. And we really have to acknowledge that science has taught us more. So how do we make these decisions about what to do with our education approach? So in addition to following the number of cases and the percent positivity and the things that we see on the news every night, there are a number of other things that are worth looking at. So do we have evidence of in-school transmission? Do we have a way to track the number of people that are positive? Can we look for clusters within these schools that might concern us? Do we have adequate symptomatic testing? And as a physician, I can say it still frustrates me that we do still have this bottleneck in terms of getting rapid PCR testing when people are symptomatic. It's getting better, but we do have a ways to go. But we need to provide that to all of our towns to get kids back into school. And then finally, what is the feasibility of in-person learning? Do we have enough adults that are well that they can be in the building and supervise and educate our children? So as more and more people get sick, we do have to be prepared that if too many people are out sick, that it will be difficult to open schools. So what do we know about COVID-19 cases in schools? So just because you identify a case of COVID-19 in a school does not mean that someone caught COVID in the school. We have to acknowledge that we're not going to be able to keep COVID out of the building. People are going to be asymptomatic or pre-symptomatic, and they may come to school. But I think we should also acknowledge that the school environment is really a pretty safe environment. It's much more controlled than being in the community. In many ways, it's safer. And we know from experience from a number of countries in Europe that have sent children back to school, that we can safely reopen schools despite high rates in the community. And we have a great deal of evidence from colleges and universities that have gone back. And we know from all of their data that when people are masked and physical distancing is maintained, that there really is very little evidence of transmission between students or between students and faculty. So these are our layers of protection. And we know that they work. We know that they work from hospitals, and we know that they work from other school systems. Masks, physical distancing, hand hygiene, which I do think gets overlooked sometimes, de-densifying spaces, improving ventilation, and cleaning and disinfecting. And this is a nice cartoon that really shows the layering of the different mitigation strategies that we have. So again, we know that cloth masks aren't 100% effective, and that's okay, because we have layered on top of that other modes of preventing transmission. And so when you combine the masks and the distancing, de-densifying spaces, hand washing, cleaning the environment, you really can see that you can prevent spread, if not with the first layer of protection, but you've got these multiple layers that ultimately will help protect transmission. And DESE came out in their guidelines with really a summary of the different strategies that you can take. And I think it's worth reminding everyone of what these are. And the reason I do this is that it can be really overwhelming to feel like you have no control over what's going on with COVID, and you feel that you have no ability to control your risk. But in fact, you do. These are all things that you can do to protect yourself and your family. So the first one I list here is really obvious: stay home when you're sick. If you feel like you have a fever, you're coming down with a cough, things like that, don't go to work, don't send your child to school. Masks, we know that masks work. COVID spreads primarily through respiratory droplets that are released not only when people are coughing and sneezing, but also when they're just talking. And so these droplets can land on people who are near you, they can land on surfaces and infect people through that mechanism. So face masks can filter these viral particles. You want something that's 2 to 3 layers thick. You want it to fit properly so it's not falling off your nose. And really, if anyone asks what's the best mask to wear, it's really the one that you're comfortable wearing, that you'll wear through the day. Physical distancing, there is some confusion here. We know that if you limit close face-to-face contact, that you can prevent spread. The CDC recommends 3 feet of distance. And in their guidelines, DESE said that you could consider 3 feet of distance as well. This is based somewhat on what we know from European studies. The World Health Organization actually recommends 1 meter distancing, which is around 3 feet. So there may be situations where 3 feet of distance is equivalent when the risk is moderate to low. Hand washing and hand sanitizing. I'm the type of person who literally I can't walk past a hand sanitizer without using it. It's just become a part of my day. And I think that's important to remember to do as well, because these infected droplets that come out of your mouth and your nose can land on nearby surfaces and very high touch areas like doorknobs, computer keyboards, things like that can transmit infection. And then just to close again with the Swiss cheese model of prevention, I think the fact that we now have COVID-19 vaccines available, this will add yet another layer of protection onto the mitigation strategies that we already have. Now I have to figure out how to unshare my screen.
Might be at the top of your screen, Robin. Oh, there you go.
Yeah.
Okay, great. So we are going to get ready to move on to the question and answer portion. Before we do, I want to ask Dr. Levitz if there's anything that he wants to mention or share. We've got a couple of people with hands up and a couple of people with questions in the Q&A, and I know there's at least one on YouTube, but.
No, let's hear from you guys out there. So great job, the rest of you, and said everything that I would have said and a lot more. So let's get to your questions and comments.
Okay, the first question is, when will my students receive the vaccine?
Well, I'll be happy to tackle that one. The vaccine is the Pfizer vaccine is approved for individuals older than the age of 16. And the Moderna vaccine is for individuals older than the age of 18. So neither of these vaccines will be offered to children until they're tested in children. So I guess there are some 16 and 17-year-olds and even 18-year-olds in high school. And they would presumably, if they don't have medical conditions, they would be offered the vaccine somewhere around March or April in the group 2. Unfortunately, we don't think that there'll be a vaccine available for kids until about the last quarter of 2021. That's when most people predict there'll be a vaccine for kids.
But it's worth adding also that children generally do very, very well. First of all, they don't get COVID as often as adults do, but when they get COVID, the chances of their getting severe COVID are a lot less. So to emphasize to emphasize what Doug said in his presentation, the state is prioritizing groups based on risk of getting COVID and risk of having a poor outcome when they get COVID. So children are not going to be prioritized, but eventually I'm confident that the vaccine will be available for children.
I also think that once the adult population is vaccinated, there'll be so much less COVID-19 around, there won't be that much COVID left for children. They won't be getting infected.
It kind of leads us right into the next question. It says, according to Paul Offit, CHOP, on 12/31/20, we do not yet know if the vaccine presents, I think it's supposed to say prevents infection or just disease. Is it possible for people who have been vaccinated to still spread the virus? Most families will not be able to get vaccinated at the same time. With data showing low in-school transmission, do you feel it is safe for our students to return to school before being able to receive a vaccine that is yet to be indicated for people under 16? So if I could take a swing at this first, just in terms of what the school department is thinking. We still recognize that our older students at the high school level are at a greater risk both of contracting COVID and of spreading COVID than our younger students. And as we start to think about safe ways to return to school, that plays into our thinking. When we have staff that are vaccinated and we know that our staff are safe, I think our first response is to look at which students are the safest to return and then start expanding from there. And I invite the doctors to give us feedback on that strategy and also add to any answer to that question.
Well, I will address the issue of whether or not you can get infected after being vaccinated. This is a more of a theoretical concern, in my view, than a serious. I mean, I respect Paul Offit a lot. He's a very well-known pediatric infectious disease specialist, I think, from CHOP, Children's Hospital of Pennsylvania. But I don't really worry about this very much. The studies that have been done in animals suggest that once an animal has been vaccinated, like a monkey has been vaccinated, that you can get a low-level infection in these animals, but to detect it, you sort of have to put a bronchoscope down into their lungs and do a washing. And I really don't think that this is what's going to happen. And I think that there's going to be, and they don't all show that you can actually infect an immunized animal. So I suspect that the level of virus that is produced after vaccine is so low that people are essentially non-infectious. Does that mean that they're not infectious? Well, probably not, but I think it's going to be one of those very, very rare events when somebody gets vaccinated, gets infected, and then goes ahead and infects somebody else. We'll know the answer to this pretty soon because we've already immunized several million people. And so we'll know whether someone who's immunized can bring COVID home and give it to their family.
Yeah, I agree with Doug, but I would add that until we know, it's important to maintain, if you're vaccinated, you still, I've been fortunate to have been vaccinated. I'm still wearing a mask. I'm still doing the social distancing, doing everything else. But I do think it's very safe. And, you know, there's a study in Sweden. Sweden did not closed down their schools. They kept them open. They had millions of school children. They had very, very few cases of severe COVID. Less than 1 in 100,000 children got severe COVID, and this is even without vaccination in the community. So I think for our children, it's going to be less of an issue. I would be interested to hear from people who are, because you hear a lot in the news about people who are hesitant to get vaccines. We have nurses in the hospital that I work at, even some doctors who are reluctant to get vaccinated. So I'd like to hear from some of those people and whether people are afraid to get vaccinated or have questions about side effects that may not have been mentioned.
Yeah, maybe I can address one of the questions that I think it's disappeared about allergies.
Mm-hmm.
Okay, so yeah, so I mentioned during my little presentation that there have been people who've had anaphylactic reactions to the vaccine, and the CDC has directly addressed this. They've come out with the recommendation that anybody who's ever had a reaction to a vaccine, actually, after they get vaccinated, wait around for 30 minutes so that we know that they're not going to have an anaphylactic reaction. And all the vaccine centers have been required to have a medication available to treat you if you have an allergic reaction. What has been seen is that the people who have had the allergic reactions to the vaccine are people who have had previous allergic reactions to vaccine. In fact, the two people in England who had the first anaphylactic reactions, they both had EpiPens in their pockets. So that they knew that they were prone to allergies and they were all ready for it just in case it happened. The only people for whom the CDC says should not get a vaccine are people who have had allergies to any of the known vaccine components. That basically boils down to if you have a reaction to the first vaccine, you shouldn't have the second vaccine. But that's basically it. So because the vaccine components, frankly, have never been injected into, except for polyethylene glycol, the rest of them have never been injected into humans. RNA is not a cause of anaphylaxis. We all have tons of RNA in our body right now floating around. It does not cause an allergic reaction. So it has something to do with what the vaccine is mixed with that causes this allergic reaction.
And I will also comment that some of the allergists at MGH have also come out and said that polyethylene glycol, there are folks out there who do have an allergy to it. It is rare. Something that polyethylene glycol is in, it's essentially Miralax or Benefiber. So it's out there over the counter. So if you've ever taken Miralax or Benefiber, you've taken polyethylene glycol. And yeah, so that's pretty much like PEG in a nutshell. So we're prepared to monitor for anaphylaxis and other side effects post-vaccine. During all of the vaccination clinics, there's 15 minutes baked into the end of it. So I had to sit in a room by myself for 15 minutes and monitor for symptoms of any sort of allergy. And if you have a history of anaphylaxis to say peanuts or something, they'll keep you there for 30 minutes. So.
Right.
You reminded me of one of the questions that I've heard repeatedly, which is, it's such a new vaccine and they made it so quickly. How do we know that it's safe?
Well, I mean, I think that's a very fair question. And no vaccine's ever been made as fast as these two vaccines have been made. And the reason we know it's safe is because it's been tried in so many people.
Yeah, over 2 million people have gotten it in the United States already. And there have been a few, less than 1 in 100,000 do get a reaction to it. Nobody has died from the vaccine. On the other hand, I'm sure people have seen the COVID death numbers. We're going to be at over 400,000 deaths in the United States from COVID pretty soon. So, if you want to, if you want to take your chances, I would go for the vaccine over getting COVID 100 days out of 100 days.
I also want to point out that though the vaccine itself has been made pretty quickly, this mRNA vaccine technology has been around. It's been around for at least a decade. It's been experimented for other types of vaccines like the flu vaccine, Zika, I think rabies. So it's been injected into animal models and the like for in an effort to develop it for the flu vaccine too, to kind of utilize this technology in the flu vaccine and in a Zika vaccine and rabies. So it's been around. It's been utilized. It's not something that we just decided to slap together over 2020. It was something that had already existed, and we decided to utilize to our advantage in fighting this this virus. And something else that Doug mentioned too is we all have RNA in our bodies. It is something that's already part of us, and it makes us who we are. So it's already there. The mRNA that we're injecting that makes the spike protein to help train our bodies to fight COVID, that actually also gets degraded pretty quickly. I think, Robin, I think you might have said before the half-life is like on the order of like minutes, like 40 minutes or something. Or maybe someone else said that to me at one point, I don't know.
Actually, the company went looking to see how long they could detect the vaccine after it was injected. And after 40 minutes, the vaccine can no longer be detected.
Yeah, so the actual mRNA that we're giving you guys has a very short lifespan in the body. The only thing that's going to be left is just the protein that is what your immune system is going to use to build kind of like a roadmap on how to fight this virus, so that you don't ever get sick enough to go to the ICU or anything like that.
And if I can add, we're all sick and tired of COVID. Believe me, a lot of us had no holidays. Two of us dealt with very close relatives who got very sick with COVID over the holidays. We all want to be over this, and it's estimated that probably about 80%, 4 in 5 people will have to either get vaccinated or actually get COVID in order for COVID to go away as a disease in this country, in order for us to return to normal. So to me, I look at vaccination as something that is good for me. It's good for the patients I take care of. It's good for my wife, who I could come home and infect. It's good for my family members. It's good for my friends. And it's good for the community. It's good for that business owner who's not able to reopen because there's so much COVID in the community. It's good for the schools, to get them to reopen safer and sooner. So part of what I look at vaccines, I look at it as a civic duty, as something that I'm not only doing for myself and my immediate family, but that I'm doing for the community. And I hope that a lot of you look at that too. You're protecting yourself, and you're protecting you're protecting Revere and Massachusetts and the country.
So there are several questions around pregnancy and maternity, and I know we touched on this a little bit, but one of the questions is, what about nursing mothers? And the other one is a question about, you had mentioned that there were a couple of women in the trials that got pregnant during the trial. Were there any women who were already pregnant who participated in the trials, if you know that?
So both Moderna and Pfizer excluded women who were pregnant from being enrolled in the trial. So the pregnancies that were seen in the trial were women who were not known to, they didn't do a pregnancy test to get in. So there were some women who didn't know that they were pregnant and were enrolled. And then there were women who got pregnant during the vaccine trial, and they were not kicked out of the trial. So that's where we have the direct data. But the truth is that very few, if any, vaccines cause problems in pregnancy. And there's a huge amount of experience vaccinating pregnant women, and there's no reason to believe that this vaccine should be different from any other. It's not an infectious agent. It's not like you get a tissue where you've been vaccinated and then your natural enzymes in your body chew it up and it disappears. So it's a very, very safe vaccine. And it's for that reason that the American College of Obstetrics and Gynecology strongly recommended the vaccine for pregnant women. And I should have mentioned women who are breastfeeding as well. Really, pregnant women are at a much enhanced risk of doing poorly with COVID-19. And this is the way to protect themselves and their babies.
I'd like to add that women were excluded from the clinical trial. Pregnant women were excluded, not because we don't care about pregnant women or we don't care how they will do to the vaccine. It really has to do with the way clinical trials are done. You have to sign informed consent. And so if you're pregnant, you really need to consent for yourself and for your unborn fetus. And so since the reason you do the clinical trial is to find out if something is safe and effective, pregnant women are often excluded from clinical trials. But now we're at a different place. Now we know the vaccine is safe and we know it's effective. And so now we can give it to pregnant women knowing that we have a benefit to reap from giving them the vaccine.
One of our listeners is asking, will the vaccine be free?
As far as I know, the answer is yes.
Yep.
I don't
Mr.
believe
Mayor, maybe you know that one.
I don't believe you can buy it if you try to buy it.
And I don't believe we are checking insurance information either when we administer the vaccine, so it should not be billed to your insurance. Mine was not checked. We are not checking MGH, and I don't believe that the clinic for first responders will be checking.
I've been helping with an assisted living place in terms of vaccinating, and they are asking for insurance information, but they are vaccinating everybody for free if they don't have insurance.
We plan on vaccinating everyone free, as Dr. Kong mentioned, and obviously not asking for any insurance information. And every indication that I've gotten from the governor and lieutenant governor in our weekly calls has been that the vaccine would be free and that it would be available without any requirement of insurance information.
The next question is, if a person already had COVID-19, do they have to get the vaccine too?
This is a great question.
Yeah, it is. The answer is it is recommended. The ACIP, which Doug mentioned, the advisory panel said that you could choose to wait 90 days until getting vaccinated. You should not get vaccinated when you have active COVID, but after you've recovered from COVID, it is recommended that you get vaccinated. The vaccine actually, believe it or not, stimulates a much, much stronger immune response to protect you than does natural infection. And as Doug mentioned when he talked about the coronavirus, that this particular coronavirus that causes COVID, there are other coronaviruses that are cold viruses, and people get the same virus over and over and over again. So it probably, the recommendation is that you do get vaccinated, but you can wait a little bit. We are seeing some reinfections. It's not known how common reinfections will be, though, with COVID-19.
Okay. What about medications? If I'm already on certain medications, should a person worry about the vaccine interacting with them negatively?
I'm not aware of any medications that are contraindications to getting the vaccine. Think of it kind of like the flu vaccine. There are no medication contraindications to getting the flu shot. And as far as I know, there are none as well for the coronavirus vaccines. Doug and Stu and Robin, correct me if I'm wrong.
I agree. I agree in that. And the other thing is that if you're on medications, it sometimes means that you have diseases that put you at increased risk of having severe COVID or even dying if you get COVID. So in actuality, we recommend the vaccine.
Okay. The next question, this is probably for the mayor as well, or me. We can try to answer it together. And there was actually a question on YouTube about when it comes time for teachers to be vaccinated, will we prioritize teachers who work with the highest needs students before other teachers? And then there's also a question about who will administer the vaccine, and where do I as a teacher go to get it? Where do community members go? Where do students go, et cetera? So I'll start by saying we anticipate that all teachers will get vaccinated in the same time window and that it would happen over several days. We are fortunate in Revere to have a great Board of Health that's taking a leadership role on this. And they're actually hosting their first vaccination clinic starting on Monday for first responders from Revere, Chelsea, and Winthrop. It's about 900 people that they'll be vaccinating over a couple of days in that clinic that's going to run out of the Rumney Marsh Academy. And we anticipate that when it comes time for teachers to receive the vaccine, that we will set up a similar kind of clinic, and we have roughly the same number of staff members, a little bit more actually, in Revere that we would be looking to inoculate at that time. And Dr. Kong, I think you have some correct information on that clinic.
Yeah, so it's actually on Friday the 15th is when we're starting. There's a couple other cities starting on Monday. You're right, Diane, but we're starting on Friday, Saturday, and then I think the following Monday. So I will be there vaccinating too. So maybe I'll come back to the teachers too. Yeah. So I will be among those.
Several of our school nurses are working together with the Revere Board of Health and their lead nurse to actually do the vaccinations, and they're engaged in training right now, and they will be leading the way for us in Revere. I don't know if Mayor, you want to add to that?
Yeah, Dr. Kelly, I would add that we, as you mentioned, we've taken a leadership role between the communities of Revere, Chelsea, and Winthrop, and we've been the main point of contact, and we'll be administering the vaccine for our public safety folks for those three communities at the Rumney Marsh Academy. I expect that we would have a similar rollout as we go through the prioritization in the list of priorities in terms of community members and others that end up receiving the vaccine. That we'll have it'll be a very similar process to what we're doing with our public safety folks. So this is kind of the first run. As you mentioned, we're incredibly lucky to have so many great staff members, especially Lauren Buck, who's our Director of Public Health. All of the public health nurses have really stepped up, and the school nurses have stepped up to be able to make this a smooth process. And as Dr. Kong said, we will begin that on the 15th. We do have it's 600 doses that we have, and that's how many individuals we expect to vaccinate And that's between Revere, Winthrop, and Chelsea. So when we get into school officials and as we expand our numbers, I know it'll be a bigger operation than the public safety folks, but I expect that we'll continue to do that on a regional level as well. So there'll be a lot of coordination and a lot of work going in to make that a smooth process. But we expect it to be similar to what we do for our public safety folks.
The next question actually comes up twice, once on YouTube and once here in the webinar, and it is, once you have the vaccine, both doses, are you finished? Do you only need it once in your life, or is this something that we'll have to get annually like we do with the flu shot?
Time will tell. I think I think the anticipation is that immunity will last for years based on what's known, but this disease has only been around for about a year now, and the vaccine has only been around for maybe 6 or 8 months. So we don't know how long immunity will last. My guess is that we will not need additional booster shots in the future, but time will tell.
Yeah, it could really go either way, because if you remember H1N1, that was pretty prominent several years ago, and it kind of just, it just kind of disappeared and went away once we had the vaccination efforts created. It just ran out of hosts to infect. So hopefully the same thing happens to SARS-CoV-2. But worst case scenario is that it will need to be annually, and it may even be combined with the flu vaccine. So only time will tell.
Yeah, it's also possible the virus will change a little bit. The flu virus changes a lot, which is why we need shots every year. Coronaviruses tend not to mutate or change all that much, but it is possible that a new strain will emerge that would necessitate the need for another vaccine or a modified vaccine. I think none of us have a crystal ball, but what I can say is that if you have a chance to get vaccinated, I would try to be first in line, or one of the first in line. It's an amazingly good vaccine, and I can't emphasize enough the importance to yourself and to your family and community to get vaccinated.
Okay. We have several questions about school reopening, and I'm going to save those until we get to the end. We're a little bit over time now, but I just want to try to get through the last couple of questions that people have here. One of them is in Spanish, but I think I can translate it. When will the young children get vaccinated?
Yes.
And Doug, maybe you can check my translation there.
Well, I can't read it, so is it on the Q&A?
Yeah, buenos los niños cuando recibirán la vacuna.
Muy bien, Stu. So the answer to that question, I already answered it once already in a way. The answer to that question is that there's no vaccine yet that is approved in children. And we think that there will be an approved vaccine at the end of 2021. Las últimas meses de 2021.
Okay, I'm just scanning here to see. There's a question on YouTube. I feel like this was kind of answered, but I'll put it again. What about people who do have allergies, egg allergies, peanut allergies, and can't take the flu shot at all? How will they be able to get the COVID shot? And what about the people who can't take it due to medical health reasons? What will happen to them?
There's no egg in the either coronavirus. there's no egg, so that's not a contraindication. So you should still be able to get the coronavirus vaccines as long as you don't have an allergy to one of the specific components in the vaccine. For those who have an allergy, especially if you have anaphylaxis to peanuts, it's recommended that you stay within the vaccine center for 30 minutes. So not the 15 minutes that everyone else will stay, but you stay there for 30 full minutes, so we can make sure you're not experiencing any sort of local or systemic reaction to the vaccine. So you'll still be able to get it, but we just need to take a little bit of extra caution to make sure you're not experiencing any adverse events from the vaccine or related to the vaccine. I'm sorry to interrupt, Doug, go ahead.
No, I think that those are all good points. This vaccine is not made in eggs, and it's not made in any environment where food products can get into the vaccine. So there should be no worry about an egg allergy or a peanut allergy or anything like that. The allergies don't occur on first exposure to an allergen, which is to say you need to be exposed to some chemical first before you get an allergic reaction to it. And there's nothing in this vaccine that anybody has that your immune system has seen before. So I think this is it is a concern. Allergies are clearly a concern, but it's a tiny concern. 1 out of 185,000 people are getting a serious reaction, and compare that to something like 2 to 5% of people who get COVID have severe disease, so and may end up dying. This is really a tiny little contraindication. If, of course, as I mentioned earlier, if you do poorly with the first shot, you shouldn't get the second shot. But those people will probably be protected pretty well anyway. They'll probably about 80% of them will be protected from COVID-19. But the second shot will bring it all the way up to 95% or better.
All right, this next question I think is for the mayor. Is there any indication that Revere will or should revert to phase 2, perhaps modified like Boston has, until the vaccine rollout has been more widely accomplished?
So we've talked about this a lot, and it's really clear that the rollback, the rollback wasn't much of a rollback, but the rollback that we saw Boston and some other communities partake in really didn't apply to the city of Revere. They had closed down museums and some other cultural facilities that we just don't have here in the city of Revere. They did close down, or some communities did different things around bar seating in restaurants. I think we have less than a handful of establishments that are doing anything like bar seating at all, and all of them have partitions and certain requirements that go beyond what some places are allowed to do in terms of additional kind of safety precautions. So there wasn't a real, I didn't see the value in saying that we're rolling back because we're going to shut down cultural facilities and entertainment complexes and museums when we don't have any of those kind of institutions in the city. So we're going to continue to make really informed decisions that are driven by data that we have in terms of how we recover and how we kind of regulate businesses in our community and other establishments. But I know that as we roll out the vaccine, and I'm incredibly thankful for this team and for the team that we have working on rolling out the vaccine, that it will be a smooth process, and that it will be the light at the end of the tunnel that I think everyone is desperately looking for. And as we move through the next few weeks and the next few months and we distribute the vaccine, we will make the decisions that are necessary in terms of the operation of certain establishments and other kind of venues. But a rollback right now probably isn't going to happen.
Thank you, Doug. I believe there was a question that you were going to answer listed in Spanish.
Which one? It's the same. Okay. Well, I'll try to answer it in Spanish. Okay.
I just got a note that says Doug Golenbach would like to answer this question live. So I don't know.
I guess, oh, that's because I clicked on answered live. I thought I was going to be able to type it in, but
okay.
It says here, quiero saber los niños en edad escolar cuándo serán vacunados. And I will say la vacuna no está autorizado para el uso en menores de 16 años. Esperemos tener una vacuna en niños al final de este año, probablemente como diciembre. Okay.
And can you give us a brief summary of that?
Yeah, the vaccine is not yet approved in children, and we hope to have it by December.
Okay, thank you. One more allergy question. What about if you're allergic to dyes used for medical procedures? Would that be something that would prevent you from getting the vaccine?
No.
Nope. All the dyes that are injected for, say, CT scans or MRIs or whatnot, that is a completely separate allergy. None of that is in either of the vaccines for the coronavirus. So you are good to go.
Okay. And then how long do folks think it will take to get everybody vaccinated?
A really good question. I mean, I think obviously the country is going to try to get as many people who want the vaccine, get it as fast as possible, but just recognize that it is a 2-shot series. So you get the first shot, and if you got the Moderna, you have to wait another 4 weeks at least to get the second shot. So that a lot of people in this country who need not just 1 but 2 doses of a vaccine. So we're we're trying our best. I think right now the United States is underperforming in their promises to get a certain number of millions of people vaccinated. So it's been a little bit of a slow start. But hopefully once we get through this slow start, I'll tell you from our experience in Revere, we're going to be rolling out vaccines for first responders. And, getting this vaccine clinic up and running is always the most time consuming. But once it is up and running, once we get more vaccines shipped out to us, and once we can get the teachers vaccinated, well, we'll already have everything in place. So I'm hoping that it'll just kind of be smooth sailing and we'll already have the building blocks in place. And it's just a matter of doing it and getting it done. Another thing too is I think at some point when it gets rolled out to the general population to address access issues, I imagine that perhaps primary care offices can start to offer the vaccine. I know my clinic, we don't have any vaccines, zero at all. Part of that is because the Pfizer vaccine needs to be stored in an ultra cold environment that we don't have. But part of it is also that, unlike Pfizer, Moderna, you just need a regular fridge, and we have that at the clinic, but there's just not enough yet right now. They're still actively producing it. So we got to kind of wait for as many shipments as can feasibly be created. So I think at some point, I hope that our office can start to provide the vaccine for all of our patients and for the community, and that will speed up how fast we can deliver this vaccine to as many folks who want it. So hedging a little bit, but I'm hopeful that the first few months we're going to have some hiccups, but once we get the processes in place, it's going to be smooth sailing.
And also, I mean, there are other vaccine formulations in the pipeline. And so right now we're dealing with the storage issues for the Moderna and the Pfizer vaccine, but there are other candidates that are moving up the pipeline and will hopefully be approved as well. And one of them will require only 1 vaccine shot. Others can be stored at regular freezer or refrigerator. So hopefully by the time we get to the point where we can actually have enough to vaccinate the general population, we will have these easier to administer vaccine formulations.
Okay, I want to thank you all. So, oops, sorry, go ahead, Doug.
I just want to say Dr. Fauci, Anthony Fauci at the NIH has suggested that we'll pretty much be all immunized by August. But he doesn't have a crystal ball either.
Yeah. So I want to thank you all. I think this has been terrific, and I feel like the exchange of ideas has been really helpful. I know that many of the people listening also have questions about when school is going to reopen, because we are still fully remote in Revere. And we did have a joint meeting of the City Council and the school committee to discuss this in December, just before the break, and not much has changed since then. It is still the goal of the school committee and my goal and the goal of many teachers to get kids back into classrooms as soon as possible and as soon as it's safe to do so. I feel like we are incredibly fortunate in Revere to have Dr. Kong leading our Board of Health, but also to have these great friends and Dr. Golenbach and Dr. Ingalls and Dr. Levitz, who are willing to come here. This is the third time now to talk to us and help us better understand the science behind what's going on in a very chaotic time that many of us, I know I, struggle to understand. So we will continue to consult with all four of these doctors and to listen to the Board of Health and the Department of Education with the goal of getting kids back as soon as it is feasible to do so. Our priority has been and still is to bring back our high need kids. And those are the kids who have special learning needs that make it very difficult for them to learn remotely. And then to continue to introduce more kids back into in-person learning, starting with the safest groups first. And I kind of alluded to that earlier when I said, we know that older kids do transmit the virus. And it's going to be a while before we can get them access to the vaccine unless they have underlying medical conditions. But we know that younger kids are not very likely to transmit the virus. So I would hope that we can see our kindergarten, early childhood, first grade, second grade students coming back when we're in a place where the adults that are going to be around them are protected by the vaccine. That we would be in a space where the kids are unlikely to transmit to each other. And so they would be safe to be in that environment despite not having a vaccine. The middle school and the high school kids, we probably have to think a little bit more carefully about, but we still can think about bringing them back, certainly the high need kids, because we'll be able to social distance, and we have all of the PPE on hand ready to go. We have the masks and the sanitizer, we have the cleaning protocols in place. So all of those other pieces that Dr. Ingalls showed us in her presentation, all of those different layers that cumulatively make us safe are ready to go. And the key challenge with the older kids will be making sure there is enough space between them for the social distancing, because they are larger bodies and because they are more likely to contract or transmit the disease. But even when we are in a place which will hopefully be around, March or so, hopefully when we're in a place that we're talking about bringing kids back for in-person learning, we will still have the remote options for those families that need it or feel it is in the best interest of their children. So I certainly don't want the parents who remain incredibly worried or who have kids that do have underlying conditions. I don't want them to think that we're going to move to a different model and lose focus on what those kids need. That's not the case. And I think that I will leave it at that. I do want to, again, just thank Dr. Golenbach, Dr. Ingalls, Dr. Levitz, and Dr. Kong. We know how incredibly busy you all are. You're on the forefront of all of this work, and we really appreciate you taking the time out of your busy schedules to talk to us, and then to stay for an extra 19 minutes. We really thank you very, very much.
We won't charge you overtime. Stay safe, everyone out there.
Thank you.